impact on mass unemployment. Clark is estimating that Latin American and Caribbean countries will have a 5% reduction in their GDP this year. The third are the threats generated by the increased vulnerability of all the adults and other population groups with certain pre-existing health conditions. And finally, those originated from expected changes in people's attitudes and behaviors that may threaten health and well-being. COVID-19 in our region, that is now the epicenter of the pandemic. We have many countries in our region that are, unfortunately, among the top 5 and top 10 countries that are producing new cases and new deaths every day. Our region has an heterogeneous evolution in the pandemic, creating a mosaic in both of the COVID-19 in the population and the response to it at the national and subnational level. PAHO is monitoring the situation closely, particularly the convergence of these three themes: a post-COVID-19 scenario, the Sustainable Development Goals, and health equity. It is by taking this in mind that we are launching a new seminar series to open a space for dialogue, mutual learning, and regional action to ensure a healthy living and well-being of all at all ages in the Americas in our path to 2030 and beyond. The kickoff of the series, we have the distinguished presence of an old PAHO friend, Professor Dr. Cesar Victora, from the Federal University of Pelotas, and our world-renowned expert in global public health, who has been leading a massive research initiative to better understand the epidemiology of the coronavirus disease 2019, the EpiCOVID19 study from Oiapoque to Pelotas. Oiapoque is the region, the sub-region, a city, I don't know, at the northeast border of Brazil. And in general, we say from Oiapoque to Chuí. Chuí is in the Rio Grande do Sul, is close to Pelotas, but in this case, they are not extending their research to Chuí. It's only until Pelotas. So for this reason, it's from Oiapoque to Pelotas, that is saying that it is covering all regions in Brazil, north and northeast, south, southeast, and the center of Brazil. This is, as of today, they face a unique, large-scale, population-based epidemiological study on the prevalence, epidemiology, and social inequalities of COVID-19 in representative samples of the population of the 133 largest Brazilian cities. The EpiCOVID study can shed light on most relevant characteristics of the current pandemic in urban settings, ubiquitous in our region, and help us inform the policies and interventions needed to preserve health equity and advance our work for sustainable development. Well, so it's very important to have Cesar Victora with us today. Since the 1980s, he conducted research in maternal and child health and nutrition, birth cohorts studies, inequalities in health, and on the evaluation of major health programs in many countries. He was a founding member of the Countdown to 2015 Maternal, Newborn, and Child Health Initiative, and remains as one of the leaders of the Countdown to 2030 initiative. He was president of the International Epidemiological Association from 2011 to 2014. In 2018, Cesar received the PAHO Abraham Horsfield Award for Leadership in Inter-American Health. In 2017, he won the Canada Gardner Global Health Award. In 2018, he was included in the Clarivate Web of Science list of the world's highest cited scientists. From the first study showing the effect of exclusive breastfeeding in preventing infant mortality to the 4 Pelotas birth cohort studies, the longest running in the developing world, the WHO Child Growth Standards, the development of the UNICEF MICS surveys, the Lancet Initiative on Child Survival, which put health equity at the center of the MDGs 4 and 5, and produced the first Lancet series ever, and the Countdown initiatives. Cesar Victora is above all a great source of inspiration for epidemiologists around the world. Cesar, it's a pleasure to have you here, and please, you have the floor. Thank you.
Obrigado, Jarbas. Muchas gracias a todos, Oscar, por la invitación, los compañeros de OPS con quien hablamos portuñol por mucho tiempo, pero hoy voy a hablar inglés. So I'm going to switch to English because even though I'm very close to the border, we after that. So can you see my screen? Okay. So thank you again for the invitation. As an epidemiologist, we like to get our hands and feet dirty. So we like to go out to the population. And when COVID hit Brazil and other places of the world, people soon realized that the official statistics underestimate the true magnitude of the pandemic, because there are many people who have fewer symptoms, or they do have symptoms, they don't go to a facility, they are not tested, and therefore they're not counted. So we wanted to count how many people actually in the population have been exposed to the SARS-CoV-2 virus. There are very few studies like this in the world. Actually, I think there are only two. There's one in Spain, I mean, nationwide study. We're not talking about studies on a small community. There is the Spanish surveys, which had 3 waves so far of data collection. And there's our Brazilian survey. These are the only 2 that I know which are nationwide and have been repeated periodically to track progress of the epidemic over time. We used a rapid test, the one-fold lateral flow test. It's made in China. The Brazilian Ministry of Health purchased something like 500,000 tests. And so we did not actually choose the test, but as soon as we got the test, we did validation studies. And we found that compared with the PCR, the sensitivity was 85% and specificity was greater than 99%. It's actually one of the best rapid tests available. There was a comparison made by the University of California, San Francisco, of a whole number of tests, and the 2 that really performed well included the one-fold test which we used. It's based on a finger prick. You take a single drop of blood, and the result is available in 15 minutes. So while the person is waiting for the result, we can apply a questionnaire, which I'm going to tell you more about later. Now, it's really important that this is not a test for diagnosis. This slide came out in JAMA about 2 months ago. We already know that it's not fully correct, and I'll tell you why later. But if you look at this part of the curve, these are the PCR tests, which start at contagion and then they go down very quickly. And these are the antibody tests, like the one we're using. Our test measures both IgG and IgM. So we are looking at infections that took place 10 to 14 days before the test becomes positive. That's very important. It's not for diagnostic purposes. If someone has symptoms and comes to a health facility, this test won't help. But for epidemiological studies, it's well suited because it takes a while to go up, but then the antibodies remain for weeks or even months. I'm coming back to that later in the talk. But this is the idea. It's not a diagnostic test. You'll see a lot of bad press about say, oh, antibody tests are not good. Well, depend what you use them from. For epidemiological surveys, they're actually pretty good. Now, the first COVID case was officially reported in Rio Grande do Sul, which is where I live, right at the extreme south of Brazil. And it was reported in mid-March. And in less than a month, we were already doing the study in the 9 regional hubs. Let me tell you what a regional hub is. A regional hub is a city that is the center of what we call the intermediate regions, according to the National Institute of Geography. but they are places where people go for healthcare, for shopping, for services in general. So they do represent the largest cities in Brazil, and they're spread all over the country. In the Rio Grande do Sul state, we selected using multi-state sampling, so it's all household-based. We're not relying on volunteers or people who come up for testing because we know this is a biased sample. So we actually go to the homes and we select 500 people in each home in the Rio Grande do Sul. And I'm going to tell you more about the results later. We had 5 surveys so far. We are going back this weekend, back to the homes for the 6th wave. They're all funded. We have funding from the state government. We have funding from Serra Pilheira Institute, which is a Brazilian funding agency. We have funding from the medical cooperative. It's been really great to work in this because so many different people in the state have contributed to funding our surveys. So what did we find? Look at the numbers on the left, very low prevalence. Actually, I have to tell you, when we started this, we thought there was a problem with the test because we had 0.05% prevalence in the first round. Obviously, the disease had not reached us yet because the South has been spared until recently. Last survey, we already had 10 times larger prevalence than in the first survey. And we're going back this week, and I'm sure we're going to find even higher prevalence. This was published in Nature Medicine, because it was one of the very few studies with sequential measurements in the same population. So we were able to document the pandemic in Rio Grande do Sul almost before it started. We had only a few weeks, 3 or 4 weeks of the first reported case, and we were already out there doing the study. Took a lot of organization. Now, it's not an easy study to do, as you'll see when I talk about the Brazilian study. Now, the challenge then became the following. We did the first couple of rounds of the Rio Grande do Sul survey, and the Minister of Health at that stage, Dr. Luis Mandetta, was very interested. He said, I want you to do it nationally, and I'm going to pay for it. So he funded the study and nationwide, and it became much, much more complicated for several reasons. If you look at the right here, Brazil is 4.2 thousand kilometers wide from Cruzeiro do Sul in Acre, close to the border with Bolivia and Peru, and all the way to João Pessoa, next to Recife. And from north to south, we all learn in primary school, as Jarbas was said, the northernmost city is Oiapoque, and the southernmost is Chuí. Well, Chuí is not a big town, but it's pretty close to Pelotas. So that's why we had the idea of doing this logo here, which is an iceberg, because we're really interested in measuring how much of the coronavirus infection is never reported. Is at the big part of an iceberg, which is underwater. And the tip of the iceberg is what we measure using official statistics on reported cases and reported deaths. So there are 133 sentinel cities. They are all the intermediate region hubs in Brazil. We couldn't do 500 in each city, so we did 250 people. And we did 3 rounds so far, starting in mid-May, and the most recent one about a month ago. Total sample size of 33,250 subjects. And for you to have an idea, we had 2,000 interviewers out there in the field. They were hired by an opinion poll company called Ibope. It's very popular in Brazil, very efficient, very well organized. But we trained them and we provided a test. We provided individual protection equipment for all the interviewers. We tested the interviews before they went out to make sure that they were not positive. And so it was a huge enterprise. And we tried to do the field work in as few days as possible, about 3 or 4 days. Now, then the problem started. We are not sure what the origin of these fake news are, but they were certainly disseminated through robots And they basically claim there's no such research. These people are trying to get into your home to rob you and to take your things away. So don't open your home for this, for these interviews. It came out all over the country. It was amazing. As a consequence, in 20 cities, our interviewers were actually arrested by the police. And in 8 cities, the police destroyed our tests out of the 133. Obviously, part of the fault was our own, because we trusted that the ministry would be in touch.
We have a communication problem with Cesar. We lost you for a bit. It's good to have you back, and you're on mute now. But if you want, you want to share again your presentation, because we lost your screen.
Okay, good. So did you hear me speaking about our interviewers being arrested? And
that's the last that we heard.
Okay, good. So there were lots of issues with communication between the ministry and the city and state governments about the survey, and communication was not very good. And therefore, instead of doing the survey in 133 cities, we managed to complete the sample in 90 cities, which is pretty good anyway, 90 out of 133. And we tested 25,000 people instead of 33,000. We learned the lesson. And so in the next stages of the research, give me 1 second, please. Okay, so we learned a lesson. In next stages, we did much better. We now have virtually everybody sampled in all cities. But look at these 3 maps.
We're not seeing the presentation, Cesar. Sorry to interrupt.
Okay, so let me go back. Yeah, okay. Is that okay now?
Yes, now we see it. Thank you.
Okay, good. So let me tell you one thing. As an epidemiologist, I would never expect for COVID to start in Brazil the way it started. You see the 3 dates of the survey, and the squares, the large squares, are cities with 10% or greater prevalence in the general population. That's quite a lot. We learn now that there's not many places in the world where you have 10% or more. I remember Spain, Madrid was the focus of the epidemic. They had 11%. In Brazil, the first cities to be hit were all along the Amazon. And then only later we have high prevalence in places like Rio and Fortaleza and Maceió and so on. And this is what we found: 1.9% prevalence in the total sample in the first round, going up to 3.1 and 3.8. This is nationally. And these are the 6 cities with the highest number of cases in the first round. As I mentioned, they're all along the Amazon, including small cities, including fairly small cities. The second round, these are 12 of the 15 cities with highest prevalence, again, all over the Amazon, but spreading further north and further west. And so what is the hypothesis? Why didn't the pandemic start in the cities where you get a lot of tourists from Italy, from Spain, who were the hotspots for the COVID pandemic a couple months ago? I think the most likely explanation, which we're trying to test now, is that Manaus has a very big industrial area where companies, foreign companies, come and build up their industries, and they don't have to pay import tax. So they can sell electronics, for example, to the Brazilian market without importation tax. And there's lots of Chinese industries here. The Chinese took advantage of this scheme. So one hypothesis is that the Chinese came, they spread the disease in Manaus. In Manaus had a huge number of deaths. This is a cemetery in Manaus. You can see they were having to dig graves very, very rapidly. And it's a very powerful slide, I think, because it reminds us that it's not just numbers. Actually, people were dying. You know, I have almost 80,000 Brazilians have died so far due to the pandemic. So it's a tragedy. It's a public health tragedy that the number often, you know, when you just look at the numbers, you don't realize that. The other thing is in the Amazon, people travel around in very crowded boats, and boat trips can take hours or even days. And I think that explains that these crowded boats are ideal for spreading a contagious disease. And therefore, that's probably how it started hitting all the Amazon cities, one after the other.
I think we have again a communication problem. We're gonna try to resolve it very quickly. We lost Cesar. Hi, Cesar, welcome back.
Yes, can you hear me?
Yes, maybe if we share your presentation, that will save some bandwidth, and maybe you can have a more stable connection. Would that work for you?
Why don't you do that then? No, why don't you do that? I sent Oscar a new version this morning, right, Oscar?
Can you share that one, Oscar, then on your screen?
Let me continue my talk. So what we did notice in Manaus is that the number of deaths in excess to last year was much, much higher than the number of reported COVID deaths. So one more indication that the statistics were not picking up all the events. I can try to share again if you want. My internet is usually very, very stable. I don't know what's happening today, just a bad luck. So
Okay, do you have it?
Let's give it one more try, okay? If anything happens,
I think Oscar is sharing already.
Oh, okay, Oscar. Okay, Oscar, thank you. So this is the industrial area in Manaus. Next, this is the cemetery. And next, this is how people travel in the Amazon region in very crowded boats, which facilitate transmission. And the next slide is the one I was referring to. The green line is the number of excess deaths, and the blue line is the number of reported deaths to COVID. So there's a huge difference in that area. Overall, in the whole country, we found that there was about 7 infections that we detected for each reported case. But the Amazon the health information system is not as complete as in other parts of the country, such as the South or Southeast. In the Amazon, we found up to 20 cases, 20 infections for each reported case. So next, please, Oscar. Yeah, I'm going to show a number of inequalities now, but I'm starting with an example of equality. In each of these graphs, the light blue bar represents the first survey, the medium blue bar, the second survey, and the dark blue bar, the third survey. So we are seeing that women and men are affected to the same extent. There's really no difference between prevalence. We know there's a difference in mortality, but that's because men have higher case fatality. Once they catch the infection, they're more likely to die due to pre-existing conditions and life habits and so on and other reasons. But every slide here has these parts. The second one is the regions. So look at the Northeast, how fast it increased from one survey to the third in an interval of 5 weeks only. The North went up and down, and that's something I want to get back to later, because that's also in accordance with other data we have on deaths. The Southeast, Central, West, and Sul, which are the other three regions, still had low prevalence in these surveys. Remember that, as I said earlier, each survey gives us a picture that is about 14 days late. So it reflects, because the antibodies take a while to develop, to be produced. We're really, when we see a date, we should be thinking about 2 weeks before that. Now, let's go on and look at some other types of inequality. By age, we are really surprised that we have so many kids. And the next please, Oscar. There's 5.7% prevalence in young kids with a large confidence intervals, because there are not that many young kids in the survey, but it goes from about 4 to 8%, which is not what people saw in China or Italy or Spain. All these places tend to have fewer kids infected than the majority of the population. But in accordance with other studies, the highest prevalence is around 20 to 59 years old. And then people who are older, they tend to have lower prevalence, although they're more likely to die as well. Now, but let's look at the socioeconomic dimension. We had a questionnaire in which we asked about household assets. That is, what sorts of assets people have in the house? Do they have television, refrigerator, freezer, rapid internet? Do they have a car, and so on? And this is a traditional tool for equity analysis. And then we divide the population into quintiles, from the richest 20% to the poorest 20%. And you'll see that the poorest 20% in every single survey had about twice the prevalence of the richest 20%. So it's a twofold difference. And some people were, when COVID first started, it started with people who came from Spain or Italy or China, and then you see the Brazilian president being infected, and you think, oh, COVID affects all social classes. This is not true. This does affect all social classes, but it does affect the poor to a much, much greater intensity than it affects the rich. And so it's a mistaken impression that the rich are equally affected as the poor. This is not the case. And if you look at the next one, Oscar, please. This is the most striking result we had. The indigenous population has 5 times more prevalence than the whites. And the blacks and brown are the pardos. In the north, the browns are a mixture of indigenous and European. In the rest of Brazil, they're mostly a mixture of African descendants and Europeans. So a very clear gradient. Again, the people self-reported being white with much lower prevalence. There's another piece of data, next please, Oscar, which is, if we just look at the north region, we say, okay, we have more indigenous in the north, so maybe the excess of the indigenous is because they live in the north. But that's not true. They obviously, instead of having 5 times higher prevalence, if you just look at the north, the indigenous have twice as high prevalence, statistically significant difference. And even if we adjust for the asset index, we adjust for education and other confounders, we still get a doubling of prevalence in the indigenous population. I'm happy to discuss that later if you're interested. The next one shows a paper that just came out in Lancet Global Health. They didn't have enough indigenous. If you look at the bottom, they only had 7 people. but this is looking at CIS-GRIP. CIS-GRIP is a national reporting system for influenza and other respiratory diseases. And it only looks at case fatality. It doesn't really look at incidence because it's not population-based. But if you look at the case fatality looking at the non-survivors, the people who died, it's considerably higher in the Pardo and in the blacks than in the whites. So it's well in line with our study. They didn't have enough indigenous to pick up the great excess in indigenous population. Now, I'm coming to the end of my presentation. Just want to share a few more slides with you. For each city, we produce an infographic. We find it's very, very important to provide feedback directly to the cities on what's happening. So how many confirmed cases they had by the time of the survey, how many cases we found. This is Tefé in the Amazon, more infected than the number of confirmed cases and so on. So it's very important to disseminate your finding, make sure it gets back to the population and to the local health authorities in a simple and easy, user-friendly way. Next, please. Now, if you look at the deaths and cases, according to our survey, the correlation is very high. So even though there is underreporting, we have a correlation of 0.826, which is very high, which means that the deaths are showing the progression and the intensity of the epidemic. And so in my next slides confirm that. Oscar, please. Now, this one, before I show you the deaths, this is very interesting. We had the impression that the the SARS-CoV-2 antibodies would last a long time. In the JAMA slide I showed you at the very beginning, the IgG line and is particularly keeping flat. So we didn't think any city would go down in prevalence. The 5 lines on the left are 5 cities with the highest prevalence, all in the North region: Manaus, Belém, Tefé, Breves, and Castanhal. They all went down in time. We thought our first reaction, was there a problem with the sampling? But no, it couldn't be, because all 5 cities went down. And then the Spanish study came up. It's kind of hard to read here, but they had a 14% drop in antibodies using a different test and on the same people. Look, the Spanish studies, they examined the same person 3 times. We examined different people living in the same census tract. So they're neighbors, but not the same people. And the 2 papers on the right are, there's a new paper coming out every day. A lot of small scale studies in volunteers and self-selected people showing, number one, that antibodies go down very quickly, which doesn't mean that immunity goes down. It just means that detectable circulating antibodies go down. And there's also all the exciting, the very, very exciting results on T cells and cellular based immunity against coronavirus due to previous infections with other types of coronaviruses. What's really struck us is nowhere in Pelotas or in Brazil or in the world, we find more than 25% prevalence with antibodies, nowhere. And yet the cases are going down. Look at the next slide. This is the same graph that I had here. On the top are the antibody levels. On the bottom are the same 5 cities looking at deaths, reported deaths. So we know reported deaths are not perfect, but they do show trends. So as deaths go down, antibodies go down too. Very interesting and unexpected result, at least for me. Now, next, this is what happened in Brazil though. Brazil is a very heterogeneous country. The line that goes up and down, the brown line is the north. It had its peak in deaths about mid-May. It's going down very fast. The northeast is going up and still at a high level, but possibly going down. Southeast is going up and now it's flattened a bit. And look at the center west, the blue line going straight up now. This is the new hotspot for COVID in Brazil. In the south, where I'm from, also going up, the green line at the bottom. So it's a heterogeneous country. If you make one single line out of Brazil, You think, oh, COVID went up and is now stable. No, that is a misconception. It seems to be stable because it's going up in some places and going down others. Next. And then we come to all the universities that helped. Brazil has a very vibrant, well-organized public health community. We had lots of different universities helping us in the study. We had funding from a number of different sources too. Next, please. We are now facing a crisis, which is the Ministry of Health is no longer funding the study. So there's a big discussion in the news. The judicial system in Brazil, Ministério Público, wants to force the ministry to continue to fund the study. We can discuss that later, but it would be a real shame to stop this huge study now that we already have 3 phases, and we'd really like to be on the field right now doing the 4th phase, but the funds were discontinued by the ministry. Next one. I just wanted to complete by saying that it's not only doing research, it's how research is interpreted and how the different state and federal government reacted to our news. The figure on top shows the state governor, Eduardo Leite, in Rio Grande do Sul, and Pedro Alau, who's the rector of the Federal University of Pelotas. Pedro has a live Facebook session with the governor every time one of the 5 stages of the research was publicized. You know, we disseminate the result within 3 days of the end of data collection. So it's a really rapid, and the government has been taking measure. He listens to science, and he is using the information from our research to build the proper evidence-based policy. On the left, I will not comment on the person in the middle, but that's right in the middle of the pandemic, no mask, no social distancing, taking chloroquine. We all know what happened to him. He caught the virus. Apparently he is well and he will survive. But it's an example where evidence is not being used to build policy. So thank you very much. And I'll be happy to discuss with you.
Thank you. Thank you, Cesar. Thank you for sharing with us your research and these conclusions that you've come up to over the last few months of following this and developing all these efforts to not only produce evidence, but to use this in order so that better decisions can be made in terms of how to tackle this and how to close the gaps that COVID-19 is exposing. Some of which are, of course, not new and not directly related to COVID, but of the many different and maybe historic paths that our region has shared over history. Un recordatorio a todos en español. Existe traducción simultánea. Está en la parte inferior derecha de la barra de herramientas. En un link, en un botón que dice interpretación, es un círculo con líneas y ahí pueden accesar a la traducción simultánea en español. Also, I would like to remind everyone that if you have any questions for Dr. Victora or to any of our panelists, you should use the question and answer link if you are joining us in Zoom, or the chat section in the YouTube platform if you're joining us in the YouTube platform. Now, to continue with our panelists, I give the floor to Dr. Oscar Mujica, who's an advisor in social epidemiology and health equity at the Pan American Health Organization. Oscar, you have the floor now.
Thank you. Thank you, Sebastian, and thank you, Cesar, for the great presentation. Good morning, everyone. Thank you for joining in this webinar. We have just listened to a terrific presentation by Professor Cesar Victora. The Brazilian EpiCOVID19 study is indeed, as of now, as mentioned by Dr. Barbosa, the largest and only population study of COVID epidemiology and inequalities in the Americas, and we have just so much to learn from its findings. As put by Mr. Antonio Guterres, the Secretary General of the United Nations, in the past World Health Assembly in May in Geneva, this new coronavirus has brought us to our knees. And the COVID pandemic is demonstrated our global fragility. Last Saturday, during the celebration of Nelson Mandela's anniversary, the Secretary General added that COVID is exposing deep inequalities and that we need to fight this pandemic of inequality through a new social contract for a new era. In a recent paper on Nature, a call was made to reset the Sustainable Development Goals, a pandemic reset, given that the COVID pandemic has exposed, again, the fragility of these goals that rest on sustained economic growth and globalization. Around the world, a growing concern on the post-pandemic future for global health is being realized. To help us reflect on these most relevant issues, their proximal and distal effects, and the convergence and intersectionality of COVID, the Sustainable Development Goals, and health equity, today we have two distinguished panelists and colleagues. We will start with Dr. Ana Rivière-Sinamond. Ana is a public health expert with more than 18 years of experience. She has worked for the United Nations since 2002, alternating between the Food and Agriculture Organization, FAO, the WHO and PAHO at regional and country levels. Her work focuses on epidemic infectious disease, early warning, prevention, control, and emergency response. She speaks 6 languages and has lived in 8 countries and provided technical cooperation to more than 35 countries, mainly Africa, Latin America, Eastern Europe, and Asia. She is currently working in the Health Information Management Unit with the PAHO Health Emergencies Department in Washington, D.C., as an advisor for data management, analytics, and products, where she is part of the COVID-19 pandemic response team. She received her PhD in public health from the London School of Hygiene and Tropical Medicine and her master's in international health policy and economics from the London School of Economics. She also holds a master in food industry and quality management from the Institut Supérieur de l'Agroalimentaire and has a degree in veterinary medicine from the Universidad Autónoma de Barcelona. Ana, thank you for being here. The floor is yours.
Thank you very much, Oscar. Thank you very much, all the panelists, and thank you for the presentation. It has been extremely interesting. Actually, when talking about COVID, we are looking at a very rapidly spreading disease that we've seen starting in December last year and spreading throughout the continent. It has really jumped into very different areas, very different socioeconomic stratas of population, and it has really overwhelmed much of the healthcare systems in many countries, both developed and developing countries. As of today, actually, we have overall more than 14 million cases globally and over 600,000 deaths at a global level. Within the region of the Americas, we have overpassed 7.5 million cases, and we are over 308,000 deaths within the region. We've seen that in this region, we have 3.6 million cases in the United States with nearly 140,000 deaths. We have Brazil with over 2 million cases and nearly reaching 80,000 deaths. We have also Peru with nearly 350,000 cases, and the list goes on within the region. However, we have seen when we look at the incidence rate per 100,000 inhabitants, we are seeing that in the map of the Americas, the Amazon basin has been one of the most affected ones, as it was mentioned in the presentation of the Dr. Cesar Victora. So I think there are certain characteristics that we need to look at when we see these high incidence in specific areas of the continent. And one of them is particularly what has been highlighted. It depends very much on the socioeconomic status of the people who live in these areas. Some of them are not able to do telework, so they are. It's compulsory for them to go out and generate income to be able to feed their families. So sometimes these are some of the most prevalent characteristics that we can see in the areas where the incidence is higher. This is something that we have already been looking at within the organization. We've been trying to focus and develop tools that can help us identify which are the most important variables or characteristics in big cities, for example, to identify neighborhoods or characteristics that can explain why the incidence is so much higher in comparison to other areas of the city. There are many other variables that can be looked at, for example, NCDs, how many comorbidities people have and how exposed they are given the number of comorbidities that they live with. We've touched also in the presentation the excess mortality. This is another topic that needs to be really looked at in most of the countries and in most of the cities in the continent. We need to compare the data that we have now and compare it with the mortality trends in the past and see how much of these excess mortality can be attributed to COVID. We have also issues that we still don't know, such as how long does the immunity of these virus will last, and also issues about seasonality. These are things that need to be explored, and I think the presentation of Dr. Victora has been very sharp in highlighting some of these issues. These are the kind of studies that need to be performed in the region, and in other countries there are very few that have been performed, but certainly it has to be done in a very systematic way in which we can compare the results and we can draw some conclusions for future endeavors, and also for deciding and advising governments on the public health measures that need to be taken into account and implemented in order to try to contain the disease. Thank you very much, Oscar.
Thank you very much, Anna, indeed. Now I will give the floor to our second panelist, Dr. Jerry Eikeman from PAHO 2. She joined PAHO as head of the Health Promotion excuse me, and Social Determinants of Health unit in May 2018. The unit also covers topics related to urban health and workers' health, and has and plays a key role in the implementation of the 2030 agenda. Previously, Jerry served as PAHO WHO Head of Office, our PWR, in Mexico, the Bahamas, and the Turk and Caicos Islands, and in Suriname. Jerry is a Dutch national, a medical doctor by training from the University of Nijmegen, with a master's degree in public health from Johns Hopkins University. She has worked in international organizations for over 25 years and has provided technical cooperation in different parts of the world. During her 8 years in Geneva, she served as the WHO lead on the Global Occupational Health Program and as the senior advisor at the ILO International Program on the elimination of child labor. Her specialization is in public health, with a specific focus on social determinants of health, health equity, workers' health and environmental health, and urban and local health governance. Jerry, a pleasure to be with us. You have the floor, please.
Thank you so much, Oscar. And thank you very much for the invitation. And Cesar, thank you for a wonderful presentation. Very insightful, very important for what's happening in our region and actually globally. First of all, I think what you just have showed us underpins what we all have been saying, what we all know, that this pandemic has exposed and has intensified those inequalities that we already had in this region, and those health inequities in countries, between countries, etc. And often when we talk about, so why is that? What is the vulnerability that's related to that? The question is answered by related to the biological and individual attributes of people, related to the risk factors or the mortality. So when we ask which are the most vulnerable populations, we say, it's the elderly, it's the women, it's the children, it's those with NCDs, with obesity. Well, yes, these are the ones most at risk, is extremely important. But if we want to ask and go a little bit deeper and want to know why the distribution that you showed, for example, in Brazil, is happening, and how can this thinking about vulnerability help us to respond in a more effective way to the pandemic, we need to look at vulnerability and inequalities a little bit in a different setting. And it needs to be able to answer questions like, why was the implementation of those non-public health measures not as effective as we wanted them to be or as we expected them to be? And how do we consider those socioeconomic, cultural, political context in the formulation, implementation, and adaptation of the measures and the mitigation of those negative consequences and application of the measures? You mentioned, Cesar, for example, Manaus, where very clearly the labor conditions, the employment conditions, the labor migration and transportation seem to be a driving force. So these are some of the things we really need to understand to become much more effective in answering to the pandemic. And also we need to answer the question how to take into account this heterogeneity of the needs of those social groups that are considered in the implementation, when they are considered in the implementation of the measures. So this vulnerability that we're talking about is really about the social, the economic, the political, and the cultural contexts. So when we look at that within the pandemic, within COVID, what does that mean? So we have identified like how the burdens of vulnerability are playing together. So first of all, for those populations who are already in the most, the previously poor, pre-existing poor socioeconomic conditions, those conditions have gotten worse. So it has deepened the inequities that we already had. This is, for example, the case of migrants in our region, or people living in urban informal settlements where the conditions have worsened significantly over the last months. Then we see, secondly, that those groups also experience more difficulties in applying and adhering to those public health measures, like Anna also measured, staying at home, the quarantines, etc., resulting in higher exposure and higher infection rates. There, a very clear example are the informal sector workers who can't stay at home, have to go out, resulting in increased exposure, but also those in the formal sector that which is 50% of our economic active population, obviously is again very heterogeneous, and it's exactly many of the indigenous poor who work in the informal economies. Many of our Afro descendants, the poor Afro descendants, work in those conditions. So they face, because they have to go out or because they are essential workers, which are also disproportionately lower paid workers, they also face that excess exposure. And then thirdly, these populations also face a larger health impact due to the application of the measures. Again, staying at home in a room 3 by 3 with 10 people obviously has a totally different impact. So we see that those living in overcrowded spaces, women who are at home or single head of household, or where we have an aggressor in the family, the issue of violence, abuse, mental health, etc., all also increase because of the measures that have been imposed that were necessary, that are necessary. But so that's like this third burden within the bigger burdens. And finally, and that's where we all traditionally focus on and we put most emphasis on, those populations that also have comorbidities, diabetes, obesity, other NCDs. Now, these are also more prevalent in people in low socioeconomic classes. So I think it's very important to look at those burdens and of course, with the intersectionality between class, race, gender, the territory where they live in. These are things that play together and that make people much more vulnerable and show what comes out of studies like those and the other way around. The studies like those confirm what we have been seeing from literature, from case studies, and from sometimes even anecdotes from the countries. So all this, of course, is paired with an unequal access to testing and an unequal access to treatment and care, which aggravates the situation, but it's a part of that. So studies like Cesar's, they're so important because first of all, they provide us evidence to identify where is the concentration of transmission, where are the deaths, and why is it there? It provides insight on who are those populations that are affected. It also shows what are those barriers that they face and what have been the negative consequences of those measures, and what was their context, in which territory do they live. Again, it was very clear from the presentation. We're talking about cities, we're talking about the north, we're talking about a concentration of indigenous populations, etc. And then, of course, what's probably most important of all of this, it answers that how can we adapt those public health measures? How can we be more effective in responding to the pandemic and taking into account those very different realities? What additional measures need to be taken? We have to talk about social protection. If you really want people to stay at home, you have to look at the conditions in which people live if you want them to stay together for a long period, or if you want to quarantine a case in such a situation, you need to have alternatives for those population. So of course, this is important for those people, for the vulnerable, the groups and vulnerable populations, but it's also very important for the population at large. And I think what's been very interesting, that people who never thought about the word inequity or never thought it was a problem, now suddenly becomes a problem because it affects all of us in how we control the pandemic. I think the social determinants of health never have had so much visibility. If we call them like that or not, they are very visible. They've never been so important. And the action to address them is very urgently needed if we really want this new normal to be a better normal. If we want this new era that Oscar was referring to be a better one with this new social compact and contract that we really need. And if we want to comply or want to attain those sustainable development goals, obviously things will need to go in a different way. And thank you, Cesar, for putting all those arguments on the table and for leaving no one behind. Thank you.
Thank you very much, Jerry, and also thank you, Anna, for this very interesting and provocative comments on as I told you, terrific presentation by Cesar Victor. I think Cesar's work and the work of his team is reflecting very much our particular reality in the region, not just in epidemiological terms, but also in social terms, political terms, and many other avenues. I must confess that I am overwhelmed by the, not only by the size of the audience, here and also in the YouTube channel, but by the amount of questions asked. We will try to answer all of them. We will pass that to Cesar, try not to overwhelm him with that, but we will try to, I will try to present some of them. I don't think we have enough time already. I have more than 48 questions, but some of them. So without much further ado, Cesar, if I might give you, I don't know if it's one by one presentation or a question or a little cluster of them. From Angola, from the United Nations Angola, Dr. Eva Pascual sent these questions. This question: are the inequalities during the pandemic affecting all quintiles in the same proportion? Any disaggregation by regions? Any projected expected impact on SDG 3? A second question from Dr. Arachu Castro from Tulane University. Dr. Victora, what may be the causes for reduction at the same time in the incidence of antibodies and in mortality? Another third question from two colleagues from the Center, Latin American Center of Perinatology, Dr. Cerrulla and Dr. Gomez. They are asking if you had pregnant women in the sample and how prevalent was in this subgroup, and also if the data on pregnant women is disaggregated, and also from newborns. Over to you, Cesar. I will have a second round of questions after you
okay,
intervene.
So let me start by saying thank you, Anna and Jerry, for their, I would have nothing to add. I have nothing that they said would not be my own words. So thank you for putting them so eloquently. Okay, so let's go for the questions. Yeah, well, we look at every region of the country. There is the quintile pattern is present. So if you look in the north, they have high prevalence. They have the 5 quintiles up here. If you look in the south, they have lower prevalence, but the quintiles are here. So it's a very, very strong pattern. And also, the colleague from Angola asked about the SDGs, and I fully agreed. I fully agree with previous speakers that the SDGs will have to be reinvented and reconsidered. And, you know, I work with maternal and child health. The child health indicators in many countries were moving in the right direction, maybe not as fast as we wanted, but I'm sure that the impact of COVID, not only because of the disease itself, but because of the disruption in health services, will be huge. We all know what's happened to immunization in many countries, for example. Now, Arachu has a very good question, as always, on why the decline. And I think the number one thing is that we did not expect the antibodies to fall that fast. If you go back to my second or third slide, the JAMA study saying, oh no, we have IgM like this, but IgG will persist for a long time. No, whatever test we use, it's not only our own test, you know, and that relates to some of the questions I saw in there in questioning the test. Well, the test is not perfect, but there's no single test that is perfect. And we're actually going back to the high prevalence municipalities in Amazonas region. And now we're doing ELISA and a number of other tests on the same people to try to understand the decline. And actually, when I first saw the decline in Breves, which was a city that had 25% prevalence in the first round, 12 in the second, and 8 in the third, I said, oh, we did something wrong. Our sampling was wrong. We maybe didn't go to the right places. But then every other city with 20% or higher prevalence is going down. The Spanish study is going down. Studies from other places in the world are showing a decline. These antibodies don't last long. Does that mean people are no longer immune? No, because they have the memory of how to produce these antibodies. And maybe our tests put the bar at very high level. Even though our validation study showed 85% sensitivity compared to PCR, but that was PCR that was carried out 10 to 14 days before our tests. We didn't validate it against PCR carried out 3 months before our tests. Yeah. Right? So that's another interesting issue. Now, the test is not perfect, but that's what epidemiologists do, right? We have to have dirty hands and a clean mind. The dirty hands is the test, and any test we use, but we need a clean mind to interpret that. And within a survey, if we find that one social group is 5 times more likely, or one ethnic group is 5 times more likely than another, that is not due to a bad test. That is really something happening there. Now, Arachu, the test went down, And it was highly coincidental with the reducing mortality. The reducing mortality tells me that new infections are probably not happening in that city. So we have been measuring old infections, and as mortality goes down, that reflects that there are fewer infections and the test goes down too. So that's my best answer, right? This is really new. We never expected that. Our colleagues from CLAP asked about pregnant women. We had few pregnant women, very few in the sample. What I can tell you for sure is that children have high prevalence of antibodies, unlike Spain, unlike China, unlike Italy. And that they're high, but they have very low case fatality. And I saw in the questions here, somebody asked about case fatality. Overall, what we prefer to call infection fatality, and it's about 1%. When we use our data, it's about 1%. But given that antibodies go away with time, our measure of infection is also not perfect. Now, mind you, even though our test is not perfect, it's very good for, if you do it serially, for tracking the epidemic. And it's also very good for comparing groups within the population. And now I just want to get back to Jerry's point. You know, why do the poor have more? Well, social distancing is very difficult. The number of people in a home is one of the best predictor of antibody prevalence. We did that in our own data. If you have more than 6 people in the home, and that maybe explain part of the excess risk with the indigenous people, because they tend to live in bigger homes. And if you have a big home, somebody has to go out to make money, and that person comes back at home. So it's also another factor. Thank you.
Thank you very much, Cesar. I have another batch of questions, if you allow me, sure. From Dr. Claudia Travasos. Do you think Brazil has reached herd immunity with 25% prevalence of infection? How to explain the decline of cases with such a low prevalence? A second question comes from Dr. Manuel Urbina from Mexico. Excelente estudio. Felicidades, doctor Victora. 2 preguntas. ¿Cuál es la relación entre la infraestructura de servicios en las diferentes zonas y la prevalencia de casos y defunciones identificados? ¿Cuántos de los casos y defunciones identificados corresponden al personal de salud? And then a third question from Dr. Popai, Jenny Popai from Lancaster University, UK. How do we ensure that public health action to reduce the unequal impacts of COVID-19 and policy responses that aim to manage the pandemic do not unintentionally increase the experience of a stigma amongst those bearing the brunt of social and health inequities before the pandemic? Over to you, Cesar.
Thank you, Oscar. Very good questions. Claudia, yours is the $1 million question, right? Why do every study we see shows antibody prevalence that is around 10 to 20 to 25%, and then deaths go down? It's $1 million question. Part of it is because the antibodies don't last very long. So this is one explanation. The second explanation is that our tests tend to measure a bit of the tip of the iceberg, even though we're wanting to measure the bottom part of the iceberg. You know, the detectable level antibodies that our tests pick up is not perfect. And number 3, which I think is a really important one, is T cells and other types of immunity. There's a Nature paper last week. There's lots of different studies showing that people who have been exposed to other coronaviruses in the past, they tend to have cross-reactivity against COVID. It's actually very good news, I think. You know, when I realized that we're not going over 20% and mortality is already falling, I was happy, I have to say, because we were all expecting the 60 to 70% herd immunity figure, but there's much more. It's a very complicated story. We're really learning from this virus and from this pandemic every day. But you know, it's quite consistent. This doesn't mean that if you don't have social distancing, there may not be a second peak, because part of the explanation for deaths going down at some certain level of antibody prevalence is because people are really adopting social distancing. So I'm a little worried about some places in Brazil, which I think are opening up too soon in the course of the pandemic. Manuel had a question on services infrastructure. We all know that the North and the Northeast are the regions in Brazil with the more problematic services infrastructure, although we do have a Sistema Único de Saúde, national health system, which was really, really effective in very highly operational, very well staffed, and even though there were budget cuts and so on, but what the SUS did for the pandemic in Brazil is a major, major contribution. What we do find, Manuel, is that in the South, for each infection, for each reported case, we may have 5 or 6 infections in the same city, according to our study. In the North, you can have 20 instead of 5. So that the tip of the iceberg in the North is smaller because of the health services infrastructure is not being able to detect, to test, and to report confirmed cases. So I'm not sure I answered your question, but that's some insight on the difference we're looking at. And the colleague from Lancaster, yeah, I mean, this is a real challenge. The segments of the population that were already worse off to start are the ones that are being hit more strongly. So it's going to accentuate inequalities in other things, such as undernutrition in children, maternal mortality, you name it. So NTDs are possibly not related with incidence, but certainly related with the case fatality. So we know indigenous populations, they have 5 times more incidence. And we also know there's an epidemic of NTDs in Brazilian indigenous population. So the things are going to be multiplied. And this is a sort of nature of social determinants, that you have this interaction between different conditions which contribute to much higher suffering and morbidity and mortality among the poor and among the ethnic groups that are excluded from the main society.
Okay. Oh yeah, I'm mute. Well, thank you very much again, Cesar. We have several other questions, but I think that we need to wrap up because time is of the essence also. We will have more opportunities to discuss the many things involved in this convergence between COVID, SDGs, and health equity. I can't refrain, you will forgive me, but in closing, before Sebastian closes the webinar, I cannot refrain myself from telling that among the many things that I learned directly and indirectly from Cesar Victora, this great epidemiologist, there is one that struck me. According to Cesar, and I am fully in agreement, there are only 2 types of epidemiologists: social epidemiologists and bad epidemiologists. And I think that Cesar has shown us a great example of how is to do in the field social epidemiology. Thank you very much, Cesar, and thank you, Anna, thank you, Jerry, and over to you there, Sebastian. Thanks.
Thank you, Oscar. I now have the challenge to close this in the last few minutes that we have remaining. I think it's been a very exciting presentation from Cesar, and thank you again, Cesar, for sharing this with us. I'm sure that we can continue collaborating and mainly using all this information and using all this evidence to help our member states to have a better approach. Thank you, Jerry, and thank you, Anna, for your comments. At this point, I would just simply like to ask any of you if you want to make a very last message. Jerry, Anna? If we go Anna first.
Yes, thank you very much for the opportunity. It has been a very interesting presentation, and also the questions have been extremely relevant. And definitely this is something that we need to continue following up in terms of what are the most vulnerable populations, what are the specific characteristics of these populations, to try to prevent them and try to shield those populations from the disease. And there are plenty of unknowns that we hope with studies like the one of Dr. Victora, we will be able to elucidate. But still, this is a novel disease that is evolving. We are learning every day something new about it, and definitely it's going to take a little bit of time to be able to understand better the evolution of it in every country and every type of population.
Thank you, Anna. Jerry?
Yes, thank you. Well, I think studies like this and discussions like this allow us to identify, who are those populations, most vulnerable situations? What are those barriers they face? What are those consequences? And what do we need to do to make sure that with our public health measures, we are not making it worse for the populations, but better? And I think that's where the last question also came in. What do we need to do? We need to identify those barriers and consequences. And at the same time, as we implement our public health measures, our non-pharmaceutical measures, we need to also implement those social and economic policies that allow people to follow those measures and to ensure that the inequalities and the inequities are not going to be deeper because of actions that are necessary, but that can be done in a different way. Thank you.
Thank you, Jerry. And this is how we come to the end of this first webinar of the series. I would like to thank as well Oscar Mujica. Oscar, thank you for coordinating this. Would you like to add any closing remark to this?
Thank you very much, Sebastian. I just want to thank you, everybody, for being here. I think the amount of people connected actually speak by itself on the importance that the social determinants, the equity, health equity in particular, have for everybody of us. And thank you, of course, to our panelists, and most of all, thank you, Cesar. Thank you also, Sebastian. Back to you.
Thank you, Oscar. And now I want to ask also the rest of the EIH team, the Department for Evidence and Intelligence for Action in Health, that supported this and have been very active in the backstage. Antonio Sangüesa, Patricia Solis, Ludovic Reves, thank you very much for all that you've done. And of course, I would like to also thank all the team from the communications department that have supported us and made this possible. Ari Silva, Sonia May, Manuel, and of course, our translators that today supported this session that help us reach more people, not only in our region, but across the globe. So thank you as well. And thank you all for joining us and participating and supporting these initiatives. It's very important for us to maintain in contact with you. So if you have any further comments, any questions, please do not hesitate to contact us. And be assured, for all of you that have been asking on the recording and the presentation, this will be available shortly through the PAHO TV channel at YouTube, which is available, I've been told, at www.youtube.com/PAHO TV. So we look very much forward to seeing you in the next seminar, which I'm going to now present to you. We're going to be sending the save the date shortly, but as part of the series COVID-19 Sustainable Development Goals and Equity in Health, we are going to be presenting our webinar number 2, which is on the impact of the COVID-19 pandemic and inequality, social inequalities, and the promise to leave no one behind in the context of SDG 3. This will give us a chance to have the participation of expert colleagues from CEPAL, from ECLAC, the Center for Commission for Economic Evaluation at the Latin American and the Caribbean. And we're going to be talking about the economic challenges and social challenges that the region is facing and will face in the next upcoming years as a consequence of the pandemic of COVID-19, and how this will again affect our goals towards the 2030 agenda. We will have as our main participant presenter Rolando Ocampo Alcantara from the Statistical Division at the Economic Commission for the Latin America and the Caribbean, ECLAC, CEPAL in Spanish. Well, thank you all very much. Have a great day and do keep in contact with us. Thank you.